Welcome to RadOnc Smart Review RadBio Edition.
Hello.
Today, we're really going to dig into combining chemotherapy and radiation therapy.
A crucial topic.
Absolutely. Think of this as essential knowledge for radiation oncology residents. Whether you're prepping for boards or just trying to make sense of treatment plans in clinic.
Right. Our goal today is to understand that synergy, that powerful interaction, and also explore some of the newer targeted agents.
Exactly. We want to get into the why and the how.
We'll build on what we've discussed before with traditional cytotoxic drugs. We'll look at the synergistic mechanisms, cell cycle stuff, those critical normal tissue toxicities.
Yes, the ones you have to know.
Definitely. And then dive into the molecularly targeted therapies, including concepts like synthetic lethality.
I'm definitely ready for this. Understanding these interactions, it feels like where the biology really hits the clinic, It's key for optimizing care.
It really is.
And as we go, we'll try to throw in some clinical pearls, board review tips, maybe an analogy here and there to make it stick.
Sounds good. We want this to be helpful, something you can grasp and remember.
Perfect. So synergy, that's the goal, right? The combined effect being greater than just adding the two together.
Exactly. It's like radiation weakens the tumor's defenses.
And then chemo comes in with a punch that lands harder because of it.
Precisely. Or sometimes it works the other way around. Chemo sensitizes, then RT finishes it off. It's about hitting the tumor from multiple angles, exploiting its weaknesses.
Okay, so radiation damages DNA, messes with cell division.
Yeah.
But tumors fight back. They repair, they cycle. Some parts are hypoxic, right? Which makes standard RT less effective there.
Correct. Those are major mechanisms of resistance.
So what are the key chemotherapy agents, the established partners, the ones we know create that synergy and help overcome these radiation challenges, the real must-knows?
Right. These are the drugs proven time and again in combined modality treatments. Their synergy often boils down to two main things: interfering with the tumor's ability to repair radiation damage, or pushing cells into a state where they're just more vulnerable to the radiation itself.
Like which ones specifically? Let's get into names.
Okay, top of the list. Platinum analogs. Think cisplatin, carboplatin.
The workhorses.
Absolutely. They form DNA adducts, crosslinks, basically tying chemical knots in the DNA.
Okay.
Radiation also causes DNA damage, strand breaks mostly. When you hit a cell with both, the sheer amount and different kinds of damage can just overwhelm the cell's repair crews.
So it's too much for the cell to handle.
Exactly. And platins are especially good at stopping the repair of what we call sublethal damage from radiation, the kind a cell might normally fix between RT fractions.
Got it. Cripples the repair crew, adds different damage. Makes sense. What's next?
5-fluorouracil, 5-FU.
Ah, yes. Very common.
It's an antimetabolite. It messes with the basic building blocks needed for DNA synthesis, primarily by blocking an enzyme called thymidylate synthase.
Okay, so it stops DNA production.
It limits the thymidine supply, a key DNA building block. This not only slows synthesis, but critically, it impairs DNA repair. This makes cells, especially those in S phase, more vulnerable to radiation. Its cousin, capecitabine, the oral form, works similarly.
Right. S-phase target, harder repair. How about gemcitabine? See that with RT a lot, too.
Gemcitabine's another nucleoside analog, like a fake building block. It gets into the DNA and just gums up the works.
So the works, I like that.
Yeah, it inhibits both DNA synthesis and repair. And what's interesting is its potency. It's a strong radiosensitizer, even at pretty low doses.
Really?
Yeah, it can also affect the cell cycle, maybe push cells into more sensitive phases, and it's quite good at blocking key DNA repair pathways like homologous recombination and NHEJ.
So 5-FU and gemcitabine both hit DNA synthesis and repair, but gem seems maybe broader, more potent.
You could say that, yeah. Broader impact on repair pathways, even at lower concentrations.
Okay. What about the taxanes? Paclitaxel? Dostak?
Now we get into the cell cycle tango. This is important. Taxanes stabilize microtubules.
The cell scaffolding.
Exactly. Needed for mitosis, pulling chromosomes apart. Taxanes basically lock up this machinery. Cells get stuck, usually in M phase, mitosis, or maybe late G2.
And G2 and M are the most radiosensitive phases.
Bingo. So taxanes act like shepherds, herding more tumor cells into that really vulnerable G2M window right when the radiation hits.
Like lining up the targets perfectly before you shoot, that works.
Precisely. Makes the radiation much more lethal.
Okay, that analogy helps. What about doxorubicin, the anthracyclines?
Doxorubicin does a few things. It wedges itself right into the DNA, that's intercalation, disrupts the structure.
Okay.
It also inhibits topoisomerases enzymes needed to untangle DNA. Plus, it generates free radicals, causing oxidative damage.
So multiple hits on DNA in its management.
Right. All these different ways of damaging DNA and inhibiting repair synergize really well with the damage radiation causes.
More diverse damage, harder to fix.
Okay.
Bleomycin.
Bleomycin is an anti-tumor antibiotic. Causes DNA strand breaks, often via those same free radicals. Its action is sometimes called radiomimetic because the damage is similar to radiation.
Radiomimetic, okay.
And like taxanes, it also tends to make cells pile up in G2 phase, boosting radiosensitivity.
So DNA breaks and G2 arrest for bleomycia.
Got it. And mitomycin C. Last one on the classic list.
Mitomycin C is really interesting. It's an alkylating agent, causes cross-links,
Yeah.
but it's also bioreductive.
Bioreductive meaning.
It becomes much more active, more toxic under low oxygen conditions. Hypoxia.
Ah. And hypoxic cells are the ones that are typically resistant to our standard photon radiation because oxygen helps fix the RT damage.
Exactly right. So mitomycin C gives us a way to specifically target that radioresistant hypoxic population that radiation struggles with. It helps improve the overall tumor response.
It's like a specialized tool for the tricky part of the job.
That's a good way to put it. Okay, that clarifies the different strategies. Crippling repair like platins, 5FU, GEM, sinking cells into sensitive phases like taxanes, bleo, and targeting hypoxic cells like mitomycin C.
You've got the main themes. Which brings us back to that cell cycle tango. A drug's phase specificity really matters for synergy.
Right, the timing relative to radiation. Let's break that down more. You mentioned S-phase specific agents.
Yeah, like 5FU, gemcitabine, hydroxyurea, methotrexate. They hit cells making DNA.
So how does that synergize?
Well, by killing or slowing S-phase cells, you might, if you time it right, let the survivors move more synchronously into G2 or M just before the next radiation dose.
Synchronizing the survivors.
Plus, blocking DNA synthesis directly messes up the repair of radiation damage that happens during or after S-phase. It's a double hit.
Clears out S-phase, interferes with repair, okay, and M-phase specific. Taxanes being alkaloids.
Like we said, they force cells into that highly sensitive M or G2M window, accumulate them right where radiation hits hardest.
And G2 specific, like bleomycin.
Same idea. Causes a pileup in G2, another very radiosensitive phase. Enhances the radiation effect.
Then there were the non-specific ones. Alkylating agents, platinums again.
Like cisplatin, yeah. They can damage cells in any phase, even dormant G0 cells.
So how do they synergize if they're non-specific?
Their synergy often comes from inflicting damage that's different from radiation or just broadly suppressing repair pathways. Platins cause crosslinks, RT causes strand breaks. Hitting with both overwhelms the repair capacity.
Even if they're called non-specific.
Yeah, and even they might have subtle phase preferences, sometimes hitting harder in S phase because the cell's trying to copy already damaged DNA.
Okay, so even non-specifics add diverse damage or just shut down repair globally. The key principles seem to be DNA repair inhibition, cell cycle manipulation, and targeting resistant populations like hypoxic cells.
You nailed it. But enhancing the effect on the tumor usually means enhancing the effect on normal tissues too.
Ah, yes. The critical part for practice and boards. Exacerbated normal tissue toxicities. When good treatments go bad.
This is absolutely non-negotiable stuff to remember. You will be asked about these specific drug-RT combinations.
Okay, hit me with the classics. The ones we have to have locked down.
First one. Bleomycin and lung fibrosis.
Bleolung. Heard that one.
Bleomycin itself is tough on the lungs. Causes inflammation, scarring. Combine that with radiation to the chest, even moderate RT doses, and the risk of severe, potentially fatal pneumonitis and fibrosis skyrockets.
So the lung becomes hypersensitive.
Extremely. Classic board interaction, bleo-lung.
Bleomycin plus RT equals severe lung fibrosis.
Oh, got it. Next. Doxorubicin or adriamycin and cardiotoxicity.
Doxocardia.
Yep. Doxo is directly toxic to heart muscle. It's dose-dependent, cumulative. Radiation to the chest or mediastinum also damages the heart. Put them together. Significantly higher risk of severe heart damage, cardiomyopathy, heart failure.
Doxorubicin plus RT equals severe cardiotoxicity. Okay. What else is in that must-know category?
Methotrexate. Think mucositis or CNS toxicity.
Methomucositis CNS.
Right. Methotrexate is notorious for causing terrible mucositis mouth, GI tract lining. Combine it with RT to head and neck, esophagus, pelvis. It can be really debilitating.
Ouch.
And high-dose or intrathecal methotrexate plus cranial RT, big risk increase for neurotoxicity like leukoencephalopathy.
Methotrexate plus RT.
Yeah.
Bad mucositis, bad CNS issues, especially with cranial RT. Okay. Actinomycin D.
Actinomycin D and radiation recall.
Actinorecall.
This one's famous. Skin or other tissues that got irradiated before can suddenly react again, sometimes badly, when you give the drug later.
Like the tissue remembers the radiation.
Kind of. It's an inflammatory flare-up in the previously irradiated area. Classic thing to know. Actinorecall.
Okay, the toxic fatal four. Bleolung, doxocardio, methamucositis CNS, and actinorecall. Those seem absolutely critical.
They are.
Are there more general toxicities, things just universally worse with chemo-RT?
Oh, absolutely. Beyond those specific combos, pretty much any normal tissue in the radiation field takes a harder hit with concurrent cytotoxic chemo.
Like what?
Severe mucositis is common head and neck, esophagus, anus, pelvis. Skin reactions get much worse, especially with drugs like Doxo, 5-FU, Actino-D, even some targeted agents. Esophagitis with thoracic RT can be brutal, and hematologic toxicity low blood counts can become dose-limiting, especially with large RT fields or TBI plus myelosuppressive drugs.
So it's the specific drug in which normal tissues get the double hit. Requires very careful planning and monitoring.
Precisely. Okay, that covers the traditional cytotoxic partners pretty well. Ready to shift gears to the new frontiers, molecularly targeted agents.
The sniper rifles, yes. This is where things are moving fast. Instead of broad attacks, these hit specific cancer-driving pathways. How do they interact with radiation?
They block specific signals or pathways crucial for cancer cell survival, growth, and often radioresistance. By hitting these targets, we can disrupt the tumor's ability to handle radiation damage.
What's the first major target we need to know?
EGFR, epidermal growth factor receptor.
Right. Often overexpressed in head and neck, lung, colorectal.
Exactly. When it's activated, it signals for growth, survival, and importantly, DNA repair things that make cancer cells resist radiation.
And the key agents hitting EGFR.
Two main types. Monoclonal antibodies like Cetuximab, Erbitux, and panitumumab. They bind to the outside of the receptor, block the signal.
Okay.
And small molecule TKIs, tyrosine kinase inhibitors, or Lotinib, Gefitinib, Afetinib. They get inside the cell and block the enzyme part of the receptor signaling machinery.
So blocking EGFR signaling helps overcome resistance, makes RT work better. Cetuximab with RT in head and neck is the classic example, right? Better local control than RT alone.
That's the landmark study, yes. Though it comes with its own toxicities, rash, infusion reactions.
True. Okay, what about EGFR2, HER2?
HR2 is another receptor tyrosine kinase, similar structure to EGFR, big driver in some breast cancers. Overexpression can also make cells radioresistant.
And the key drug here is Trastuzumab, Herceptin.
Exactly. Trastuzumab is the main monoclonal antibody targeting HER2. Others are Tuzumab and TKIs like Lapatinib. Trastuzumab seems to sensitize HER2 positive cells to radiation, probably by blocking survival signals and messing with DNA repair.
And toxicity link. Like Doxo, Trastuzumab has cardiotoxicity risk. Combine that with chest RT.
A very important point. Definitely amplifies the cardiac risk. Needs careful consideration.
Okay, next target.
VEGF, vascular endothelial growth factor.
Angiogenesis, making new blood vessels for the tumor.
Right. Tumors need blood supply to grow. Hypoxia actually stimulates VEGF production.
So blocking VEGF should starve the tumor, or maybe make it less hypoxic for RT.
This one's a bit complicated. Agents like Bevacizumab Avastin, which binds VEGF itself, or TKIs hitting VEGF receptors like Sunitinib or Sorafenib, they block angiogenesis.
Okay.
The hope was this would normalize the tumor blood vessels, improve oxygenation, and boost RT sensitivity. But blocking blood supply could also increase hypoxia, maybe causing resistance.
Double-edged sword.
Potentially. The best way to use anti-angiogenics with RT is still being figured out. Plus, there are risks like bleeding, clotting, poor wound healing with these combos.
So VEGF interaction with RT nuanced. How about BCR-ABL?
BCR-ABL is very specific. It's a fusion protein, a tyrosine kinase made by the Philadelphia chromosome translocation, mostly in CML, chronic myelogenous leukemia.
And imatinib, Gleevec, was the breakthrough drug targeting it.
Exactly. While CML isn't usually treated with RT, imatinib is a perfect example of successful targeted therapy against a dominant oncogene. It doesn't really have a big role as an RT sensitizer in common cancers, but it shows the principle.
Targeting the key driver mutation.
Got it.
Okay, final targeted concept, and you said this is high yield. PARP, poly-ADP ribose polymerase.
Yes, this is critical, and it ties into a fundamental concept, synthetic lethality. PRP enzymes are DNA repair workhorses, mainly fixing single-strand breaks via base excision repair.
The more common type of DNA damage.
Right, and PRP inhibitors like Olaparib.
Limparza.
Yes, Olaparib, Rucaparib, Niraparib, Talazoparib, they block PRP from fixing those single-strand breaks.
Okay, so single-strand breaks pile up.
Well, if those aren't fixed, when the cell tries to replicate its DNA, those unrepaired single breaks get turned into dangerous double-strand breaks.
Ah, okay. So inhibiting PRP leads to more double-strand breaks, especially after radiation, which already causes some.
Exactly. Now, a normal cell has good ways to fix double-strand breaks, mainly homologous recombination repair. But what if a cancer cell already has faulty homologous recombination?
Like from a BRCA mutation.
Precisely. BRCA1 and BRCA2 are key for homologous recombination. If that pathway is broken, the cell becomes super reliant on other repair paths, including PRP for those single-strand breaks.
I see it now. So if you block PRP in a cell that already can't do homologous recombination well.
You've kicked out both its repair crutches. Neither PRP inhibition alone nor the BRCA-HR defect alone might kill the cell normally, but the combination is lethal. The cell just gets overwhelmed by unrepaired double-strand breaks. That's synthetic lethality.
Breaking both legs of the repair system. That's a fantastic analogy. So with radiation adding more double-strand breaks, PRP inhibitors become potent radiosensitizers, specifically in tumors with BRCA mutations or other HR deficiencies, sometimes called BRCA-ness.
Exactly right. This is driving treatments in ovarian, breast, prostate, pancreatic cancers where these mutations pop up. It's why molecular testing is now so vital.
This really highlights the shift in clinical decisions. It's not just type and stage anymore, but finding these molecular weak spots. Knowing about HER2 amplification, EGFR mutation, or critically, HR deficiency guides targeted therapy choices with RT.
Absolutely. And of course, resistance to targeted therapies is a huge challenge, and combining them with RT is one strategy being looked at to overcome that.
Can you give a quick example?
Sure. Think locally advanced rectal cancer. Standard is often 5-FU chemo with RT, using that DNA synthesis repair inhibition synergy. Now, imagine a different patient. Metastatic prostate cancer, castrate-resistant, known BRCA2 mutation, getting palliative RT to a bone met. Standard RT works for pain, but adding a PRP inhibitor based on synthetic lethality might really enhance the tumor kill there, maybe even systemically. The biology suggests the potential, even if data is still emerging for every specific scenario.
That makes total sense. Okay, summarizing. Know the classic synergistic chemo drugs, why they work with RT, repair cell cycle hypoxia, their cell cycle dependence, the must-know toxicities, the key molecular targets, EGFR, HER2, VEGF, PRP, example inhibitors, and that high-yield synthetic lethality concept with PRP and HR deficiency. Wow, that's a lot.
It is indeed. Let's try to lock in some clinical pearls and board review tips from all this.
Okay, pearl number one.
Core synergistic chemo drugs. Cisplatin platins, 5-FU, gemcitabine, taxanes, doxorubicin, bleomycin, mitomycin C. Know their synergy mechanisms, repair inhibition, cell cycle effects, hypoxia targeting.
Virtual.
Cell cycle is powerful. Taxanes cause M phase arrest, G2M sensitivity. Bleomycin causes G2 arrest.
Pearl three.
Memorize the classic toxicities. Crucial for boards and safety. Bleo lung, doxocardio, methomucositis CNS, actinorecall. And remember the general worsening of mucositis, skin, esophagitis, blood counts. Molecular targets with RT, EGFR, HER2, VEGF, PARP. Know an example inhibitor for each: Cetuximab, Trastuzumab, Bevacizumab, Olaparib.
And pearl five, arguably the highest yield from targeted agents.
Synthetic lethality. PRP inhibitors devastate cells with homologous recombination defects like BRCA mutations. This creates potent radiosensitization in those tumors. Combining two non-lethal hits makes a lethal one.
Those are the foundational ideas that always seem to come up.
They really are.
All right, ready for a quick board blitz? See if it's sticking.
Let's do it. Test those connections.
Question 1. Which chemo agent causes M-phase arrest and synergizes with radiation by accumulating cells in a highly radiosensitive phase? A. 5-FU. B. Cisplatin. C. Gemcitabine. D. Paclitaxel.
That would be D. Paclitaxel. It's a taxane, deterrence microtubules, causes M-phase arrest. M and G2 are most radiosensitive. 5-FU gem or S-phase. Cisplatin is not specific.
Correct. Question 2. Patient had doxorubicin chemo, now needs thoracic RT, including part of the heart. What late toxicity risk is significantly increased? A. Pneumonitis. B. Myelopathy. C. Cardiotoxicity. D. Nephrotoxicity.
That's C, cardiotoxicity. Doxo is cardiotoxic, chest RT adds risk. The combination really amps it up.
Right again. Question 3. Olaparib, a PRP inhibitor, shows most synergy in tumors with what characteristic? A. EGFR overexpression, B. HER2 amplification, C. Defects in homologous recombination repair like BRCA mutation, D. High hypoxia.
C, that's synthetic lethality. PIRP inhibitors block single-strand repair. HR-deficient cells can't fix the resulting double-strand breaks, especially with RT added. EGFR, HR2 are different targeted therapies. Hypoxia relates more to mitomycin C.
Perfect. Last one, question 4. Which targeted therapy primarily inhibits VEGF signaling?
Okay.
Cetuximab, B. Trastuzumab, C. Imatinib, D. Bevacizumab.
That's D. Bevacizumab. Avastin binds VEGF itself. Cetuximab is EGFR. Trastuzumab is HER2. Imatinib is BCR-ABL.
Excellent blitz. We've really covered a lot of ground on how chemo and targeted agents partner with radiation, the biology, the toxicities, the clinical implications.
It's a complex dance, for sure. Understanding these mechanisms is just fundamental to good treatment planning. And yeah, resistance to both types of drugs is a huge area. Combination strategies are key there, too.
It really is a mountain of information. Sometimes I seriously wonder how anyone keeps all these mechanisms, drugs, toxicity straight, especially, years after the biology boards. Feels like you cram it, test it, and then poof, half gone.
Huh. That's a very common feeling. Totally understandable. But the core principles we hit today, DNA repair, cell cycle, specific vulnerability, synthetic lethality, that framework lasts. It helps you understand the next drug, the next combination.
That's a good way to think about it. The framework endures. Speaking of what's next, what's our next RadBio topic?
Next time, we'll tackle immunotherapy and radiation, how radiation primes the immune system, how it interacts with checkpoint inhibitors, another huge evolving area.
Oh yeah, another massive piece of the oncology puzzle. Looking forward to it. For now, keep reviewing these Chemo+RT concepts, everyone. Practice applying them.
Exactly. Mastering these interactions is just critical for safe, effective patient care.
Complete practice oral boards at radonsmartlearn.com. That's RADONCSMARTLERN.com. And subscribe to Radon Smart Review for our next deep dive. Thanks for tuning in.